From the campus of St. Louis University in St. Louis, Missouri, HEC TV proudly presents St. Louis University's 7th Annual Safety Across High Consequence Industries Conference, where safety meets business.
Now we're going to start the series of different industry perspectives on safety management systems and how they've been implemented within those industries. This time I'd like to welcome back Tom Coons. He's participated in this conference several times in the past, and he's coming back this time to represent his experiences from the rail industry in talking about their safety management system. Tom is the co-founder and principal of the consulting firm Kestrel Management Services. He assists industrial clients in operational and business risk management, process improvement, and sustainability. More than 30 years, he's consulted with a wide variety of industrial companies in the assessment, design, and implementation of systems for quality, safety, and environmental. And a way to assist the clients in the continual improvement of industrial safety programs, he and his colleagues have designed and implemented a robust method and computerized tools to analyze human error and contributing factors in accidents, incidents, and other process failures. This method reveals opportunities for systemic improvement and preventions. Welcome, Tom.
Thank you, Jim, and good morning. Okay, let's talk first about the different structures. How do you organize a safety management system? There are a lot of different organizational structures, but it's amazing how similar they are. I think of all the presentations this morning right up to this one, you're going to see similarities. Now, in terms of certifications of systems, there are also an outside verification, validation, certifications. There are specific types that are applied in the chemical industry. For safety management, you hear of OSAS 18001. It's a safety management system structure. It's a European-originated standard now embodied in ANSI Z10 in the U.S., but it's very similarly structured to ISO 9001 for quality, ISO 14001 for environmental, even safety, food safety, 22001, and energy management, ISO 51001, or 50001, I guess it is. All of these are now harmonized in terms of their structure. In the chemical industry, most safety management systems today are being aligned or integrated with environmental management and with quality management. And security against terrorism, that sort of thing, is also integrated. Some trade associations, like the American Chemistry Council, Synthetic Organic Chemical Manufacturers, National Association of Chemical Distributors, have adopted these integrated safety, environmental, and security standards. ACC has their responsible care management system. SOCMA has the what they call Chem Stewards. NACD uses responsible distribution, and there are others that are all similarly structured. Many companies also have moved to integrate quality with safety, environment, and security, and have actually implemented their own version and branded their own version. For example, ExxonMobil's Operations Integrity Management System is a version of that. So there are a lot of similarities. You will see a lot of similarities in your systems as well. And here are largely, you saw an earlier diagram from Steve, very similar in the chemical industry. You're looking at essentially a plan, do, check, adjust cycle of continual improvement. What are your risks? How important are they? What are your controls? How do you check and assure that they're working? And how do you review it periodically to continually improve your system? The procedures that fall within each one of these are actually pretty well developed, pretty well standardized. They vary a little bit from company to company, but essentially I think this is the model most widely used by the chemical industry. Within this, a number of the key processes that are associated with risk management in that industry, you've seen them already this morning. Identifying your risk, assessing them and setting priorities, allocating resources to improvement and to control, and of course the risk management and control processes, metrics and measurement, and then defined actions for continual improvement, and learning the lessons of what happens in the system. Another view of this is the sort of thing that you see tying to the strategic planning and business objectives of an organization. And in larger, especially larger publicly traded companies, the boards of directors have moved toward a term called enterprise risk management. And it's very common in these kinds of companies, very common in big chemical companies, where you have essentially a very robust risk identification and assessment process out of that, and risks that a chemical company addresses are not only safety risks or catastrophe risks, but they're supply chain risks, they're geopolitical, they're natural gas costs and supplies, they're market variations up and down, all kinds of macro risks that apply, and micro risks. Well, a company in its looking at enterprise risks and where safety fits, that's what they're tending to do. Out of that cycle of risk review and assessment and priority setting comes the whole business of planning, budgeting, resource allocation, and getting moving on those things that the organization concludes are most important. And then way over on the right side is the plan, do, check, adjust, operational controls. That's what puts this thing into operation and sustains it with feedback. And that's an ongoing, continuous cycle. For an example, kind of a nested example of risk assessment, you kind of look at the similarities across environmental, safety, and security, for example, the kind of thing that's covered in the Chemistry Council's Responsible Care Management System. Very similar methodologies to determining environmental aspects and impacts, to determine safety hazards and risks, or security vulnerabilities. Very similar risk assessment methodologies. Some companies use an integrated risk rating and assessment so that out the bottom comes their list of significant risks against which they set their improvement objectives and targets, and drop those down into either action plans for improvement or ongoing operational controls for sustaining and continually improving. Very classic kind of approach in the chemical industry. In the area of operational controls, this is really a key element of a safety management system in terms of moving from management and company culture, aspirations, vision, mission, values, to operationalizing them on the floor, the shop floor, or in the field. And it's really an important aspect of it. It takes a lot of time, takes a lot of detailed work, it takes employee engagement to build these operational controls. But this is what is needed for reliability in terms of effectiveness and efficiency of your operations, compliance, and even financial reporting. Along the way, this is a very mundane, difficult, challenging thing, but it's how do you document your management system. It does take time and it's difficult, and but it's awfully important in safety management systems. I look around and I look at myself in the mirror in the morning. My hair's getting gray. I'm what's called a baby boomer. Well, how many more of us are going to retire from organizations, and how much will we lose the institutional knowledge and learning in the organization if we don't document our key processes and procedures and methods. So documentation is really important. It interprets what you have to do, why you have to do it, who has to do it, and how. And document control. As we work with companies on management systems, amazing the fights you can get into about document control. It seems pretty mundane and simple, but how do you name documents? How do you make them look? How do you manage version control? How do you manage updating, review and updating? How do you differentiate from one level of documentation to another? All very important in a management system. This is a very highly summarized hierarchy diagram of the documentation of a chemical company's safety management, well, actually integrated environmental safety and quality system. At the very top are you have a policy, and you have these high-level overarching management system procedures. How do you know your legal and other requirements? How do you set objectives and targets in your organization? All the way over to how do you monitor them, and how do you do management review for continual improvement? There's about 15 high-level overarching management system procedures. Then you get down to the guts below that, and now you're into the programs, safety programs, process safety programs, management of change, mechanical integrity and maintenance, all those things that make it work and operationalize it. Below that is the set of forms and tools and templates you use, and you get down below and you're into training programs, and below that you get records. And I always define a document as a description of what is to be done, how it's to be done, who does it, and a record is proof that you did it. It's just, and I'm sure you look at definitions the same way. Way down here in a chemical, this chemical company, by the way, has 85,000 documents that it needs to put in a structure like this. This is just a real summary of it. Things like batch tickets. How do you make a batch of chemicals that they're going to sell to the marketplace? All that stuff has to somewhere be in the management system. Well, in the chemical industry, regulations play a very huge role in how a company builds its environmental and safety quality system. In the area of safety, chemical industry is subject to myriad of regs. OSHA is one of the main ones, of course. You have occupational safety rules and regulations. You also have process safety management rules. EPA comes along with their pollution control, environmental protection rules, and the link to process safety, which is called a risk management program rules. The Toxic Substances Control Act deals with hazardous communication of hazards. Material safety data sheets comes out of TSCA. HAZCOM and labeling, which many of you I know deal with in the healthcare industry as well. DOT deals with hazmat, hazardous materials transportation. The Department of Homeland Security has its chemical facility anti-terrorism standards. National Fire Protection Association has a variety of standards. Some of them are electrical safety, for example. And then for chemical companies that get into food grade chemical manufacturing or pharmaceuticals, you're into various good manufacturing practice standards and HACCP, the Hazard Analysis Critical Control Point standards for food safety. One of the interests, I think you asked the question this morning about how do you regulate safety culture? It's kind of a backhanded way to regulate safety culture, but the U.S. Department of Justice sentencing guidelines for environmental and safety major things is a good incentive or a good inducement. It may not be regulation, but it's an inducement. And for publicly held companies, the officers and directors' liability exposure is also a very good tool to do what you'd call regulate safety culture. Then, of course, many companies have their own detailed policies, procedures, work methods, terminology. So all of that has to be baked into a chemical industry safety management system in some way or another. I'm going to just touch on something important that Steve referred to earlier, and he cited the example of BP's operations as kind of a classic case. OSHA regulates safety in kind of two major ways. One is the occupational safety program requirements, OSHA 1910, whatever. And there are all kinds of programs. There's things like fall protection, hearing conservation, ladder safety, machine guarding, personal protective equipment, and so on. These are the kinds of OSHA recordables that you read about in the statistics. But there's another and way more important and more substantive aspect of regulatory control in the chemical industry, and it's the process safety management regulations. They were first promulgated in 1992 and came, probably the greatest stimulant was the Bhopal, Union Carbide's Bhopal disaster with the release of highly toxic gases. The purpose of process safety management regs is to prevent or minimize the consequences of a catastrophic failure, catastrophic release of toxic, flammable, explosive chemicals. They're performance-based standards, and they basically apply to a list of these highly hazardous chemicals, HHCs. There are about 135, give or take, materials. Chlorine is an example of one of the materials that's regulated, and there are a whole bunch more that are difficult to spell and difficult to pronounce. So I won't try to do it here. One of the things that Steve mentioned was the Texas City accident in 2005. That's an aftermath of it there. Formosa Chemicals in 2005, or Formosa Plastics, had a similar one. Another company, actually in 2008-ish, the EQ company, which is a hazardous chemicals treatment and disposal company in Apex, North Carolina, all involved major accidents, major evacuations, major damage, and loss of life. And all of them are linked to failures in process safety management. One of the things the Congress did was to direct the EPA to develop a linked risk management program. And there's a regulation under the Clean Air Act in 1990 that established risk management plans. And essentially, the chemical industry looks at process safety management and risk management plans as directly linked. Process safety is aimed at preventing and avoiding bad things from happening. Risk management plan says what happens if there's a major release to the surrounding area and around the surrounding neighborhood. So the two work together to improve safety in the chemical industry. Well, here's, I'm not going to go through all these with you. There are 14 core elements of process safety management. They start with accurate process safety information, process and instrumentation diagrams, piping details, all the engineering nuts and bolts that you need to run a successful and safe chemical process. Employee participation, a clear approach to process hazard analysis. Then comes standard operating procedures, SOPs, work instructions, training, contractor safety, mechanical integrity, and maintenance programs are embedded in mechanical integrity. Right materials, right equipment for the right chemicals, doing the right thing, and maintained and kept up to date and replaced when needed. Pre-startup safety review for new processes. Hot work permits go along with this. And management of change. That's been a huge issue in big turnovers and big changes in chemical operations. Is, do you have it planned? Do you have the hazards identified ahead of time? Are you managing the process of significant change effectively? And on they go. These are the elements of process safety management. So, and you add up the comments made by earlier speakers, you can kind of see the pattern of how important this kind of thing is to the chemical industry. Has it been effective? Well, this is some statistics from program reviews and studies done by OSHA over the years that it's been in effect. And by the way, they make the point that this isn't just for some chemical manufacturing facilities. There are roughly 25,000 establishments in the U.S. covered by process safety regulations. And it's interesting, this is in 127 different industry categories, and if a food manufacturing facility or a cold storage facility or a hospital happens to have anhydrous ammonia on site above a certain threshold, you would fall under the process safety management regulations in various ways. So it's not just for chemical industry in many respects. First 5 years of PSM implementation, OSHA estimates an avoidance of fatalities and injuries and illness, and even more so in the second 5 years after implementation. And comparing first 5 years to second 5 years, or 5 years prior to PSM regs to 5 years after PSM regs, OSHA also did a study to show that there was an estimate of 40% reduction in major incidents and overall and costs during those next 5 years. There are still deficiencies in process safety management, and they range all the way across from operating procedures on down to process hazard analysis, management of change. So it's not perfect yet, but there have been improvements. One of the reasons that it isn't where it needs to be yet is really when you gauge where is your organization in terms of its process control maturity. And there's lots of ways, since PSM and safety management systems have come into play, there are lots of ways that have been found to gauge process maturity along the way. These are just some very limited indicators of where do you start, what about when you're in the process of developing your safety management system, and what are some of the attributes when it's fully functional. And I guess I draw your attention to a couple of them here in terms of how well documented the processes are. In the beginning, you're likely not to have much documentation, or it'll be sporadic, or it'll be different. You may have many versions of them. You'll also be capturing metrics that are more likely what you have to report to OSHA, the recordables. As you move up the maturity stage and get to that fully functional stage, you're going to have fewer exceptions. You're still going to have some. You're going to be well documented. You can verify and validate that your processes are largely in place and working everywhere. Your metrics are going to be leading, lagging, and even in-process measurements. You're going to be more data-driven. Anyway, these are, you have your own measures of process maturity. And it's interesting to hear our keynote speaker this morning who talked about awakening and first wave using CQI and the current initiative and current level of maturity that they've reached, now relying on Malcolm Baldrige, a more sophisticated kind of analysis and assessment of improvement. Well, let me wrap up and say that incident investigation in the chemical industry is alive and well and active. There are lots of ways to do it. We all are familiar with Reason's Swiss cheese model of layers and hazards resulting in accidents depending on holes in the barriers and contributing factors to human error and so forth. Chemical Safety Board, interestingly, just published a new policy on employee engagement in incident investigations, chemical incident investigations. And of course, they're going to they claim they're going to monitor whistleblower retaliation along the way. But that's a real important something that's been learned about incident investigation, is to make sure it is balanced, to make sure it looks at all the way up and down the chain of human intervention or activity, of processes and methods, all the way up the organizational chain. This last diagram is a picture of a human factors analysis process that starts at human error, moves up the chain, and ultimately gets up to what I think was called some of those embarrassing questions about organizational improvement needs. Well, finally, let me just mention a last thing that has become very important in the chemical industry and in their safety management systems, and that's auditing and inspections. And I'm sure you can appreciate the immensity of and the discipline required for inspecting all those pipes and valves and vessels and heat and non-heated things and on through a chemical plant. Inspections for mechanical integrity are very critical. Well, in addition to audits and inspections, monitoring and measurement is very common in the chemical industry. And it can be anywhere from monitoring and measuring the environmental emissions and discharges from a facility, to workplace exposures, to measuring and reporting recordables, and then a whole series of in-process measurements and tracking. Equipment calibration, mechanical integrity, process controls, temperature controls, pressure valves. There's a ton of monitoring that goes on in a safety management system in the chemical industry. Well, that really wraps up my review of chemical industry safety management systems. I think and I hope you're seeing some real similarities, maybe different language, but similarities from one industry to the other. That's what we have certainly found in terms of structures, in terms of plan, do, check, adjust. And I know that we're going to hear a lot more about similarities in safety culture and leadership as we go through the conference. Thanks.
I'd like to first start off with introducing our Dr. Howard Jeffries. He's an attending physician from Seattle Children's Hospital and clinical associate professor of pediatrics at the University of Washington School of Medicine. He's also the medical director for continuous performance improvements at Seattle Children's. He's a founding member of the National Institute of Health funded multi-site cardiac ICU research consortium. He's also the co-chair of National Quality Forum's Cardiac Surgical Measures Steering Committee. He's a member of the American College of Cardiology, Pediatric Cardiology, and he's led the development of a national cardiac ICU database, and he's the vice chair of Children's University Medical Group Physician Education and Compliance Committees, and I'd like to share the perspective of safety management systems from the healthcare perspective.
Okay, well, thank you, and thanks for the opportunity to speak today. So I wanted to, well, no disclosures, but I wanted to just talk a bit about where I come from, and that's up in the left-hand corner of the country. So I come from Seattle, and the hospital I work for, Seattle Children's Hospital, we serve what we call the WWAMI region. So it's Washington, Alaska, Montana, and Idaho. And it's pretty big. 23% of the landmass of the United States. And that's because Alaska's huge, but as you know, no one lives there. So it's about 500,000 people live in the state of Alaska, and about half of them live in Anchorage. So this creates challenges for us. We have a very large geographic area and have to cover that. So that raises risks because we do transport patients. And transporting patients is not without risk. I mean, there's aviation risk, but there's risk just for the patient with transport. And we do have unfortunate instances of patients who don't survive transport. But that is something that we have to try to mitigate and deal with as part of our daily work. So this is some of the statistics of the hospital. It's a 250-bed hospital. We have about 15,000 admissions a year. We do about 14,000 operations. I would say this makes us sort of a large, medium-sized children's hospital. There are clearly some bigger ones when you come out to the East Coast. St. Louis Children's is bigger than us as well, but we're sort of in the middle range. With a similar amount of staff as you see in other children's hospitals, of about 4,800, 5,000 employees. And then we have about 1,200 physicians. Again, those are not all employed by the hospital. Actually, the hospital employs very few physicians. And our physicians work through different medical groups. The largest one being Children's University Medical Group, which is an association of University of Washington Medical School and Seattle Children's Hospital. And that's the group I'm a part of. Pretty much all the teaching faculty at the hospital are also teaching faculty at the University of Washington. So this is our hospital's vision. And I think you'll find what I say similar in a lot of ways, I think, to what Sister Mary Jean Ryan said this morning. So hopefully you'll not find it duplicative, but you'll find it complementary. But we also had a search for our vision. And it took us a long time to settle on this vision. Our vision, we will be the best children's hospital. Again, very short, 7 words. And that was intentional. But for us, it's pretty easy to say, but for us in the Northwest, we sort of have a very humble culture. So for us to come out and say we will be the best took us a long time to get to that. You know, we're not from Boston. We're not from the East Coast. We don't have to bang on our chest, tell everybody how good we are. I said this actually in Boston a few months ago and got sort of mixed reaction from the crowd, but that was the way it goes. And just as we heard this morning, we struggled with things like, well, is it okay to be just the better than average hospital? Do we just want to be the hospital better than the guy next door? But we didn't think those things would sound very good for our staff. We didn't think it would sound very good for our community. And so we settled on this vision that we were going to be the best children's hospital. But this vision we settled on was probably about 12 years ago. And we were not the best children's hospital at the time. We're not the best children's hospital today. Hopefully we're further on our journey than we were. But we still had to put that out as this is where we want to be. Well, one thing I just wanted to talk about, the Stockdale paradox and how we sort of think about that. So the Stockdale paradox comes from a book by Jim Collins called Good to Great. It's a management book. It's a well-written book. And the Stockdale paradox, it talks about Admiral Jim Stockdale, who was in the Hanoi Hilton during the Vietnam War. And he basically was able to keep the folks that he was with alive and sane and get them out of that captivity eventually. But he came up with some rules that he felt were important. The first one was that you must retain faith that you will prevail in the end, regardless of the difficulties. So you have to be resolute that you are going to achieve what you're going to achieve. And in his case, it was survival. In our case, it's to be the best children's hospital. But at the same time, you must confront the brutal facts of your current reality, whatever they may. You have to realize that you are not the best, but that's your aspirational goal. And you know that there are things which are going to come along your way which are going to jolt you. But you still have to have this vision and keep moving towards it. So at the time, and this was our vision, when we set this vision, it was probably around 2000, we had safety concerns. We were injuring patients. We knew this was happening. We were hearing about it. We were seeing it. And our patients were telling us about it even when we were unaware of it. We had service deficiencies. People couldn't get in, and we never talked to them back. So when we spoke to our community providers, we said, how are we doing? And they said, you guys provide great care, but you can't see our patients and you never call us back. And so we knew we had problems. In the next few years, we also had recession-related revenue challenges with the recession of 2008. We had to think about how are we going to overcome this without firing people, without having to lay people off. And I'll talk a bit about that as well. And we had the specter of healthcare finance reform. Again, some of these are more recent realities. But I would also say that the realities that we had 10 years ago, we still have the same realities today. We still have safety concerns. And I think our service deficiencies are improving, but they're still present. And the bottom two are still as relevant then, though maybe the third one is easing a bit if you believe the Wall Street Journal. But this was our reality. We are very complex. Healthcare is exceedingly complex, and I think we heard this morning that anesthesia has done a good job, and they really have. I mean, if you look at anesthesia error rates, it's 10 to the minus 5, 1 times 10 to the minus 5 error rates, very impressive, but the rest of healthcare really hasn't followed suit. Partly it's because of the complexity. This is just diagrammatically showing you what it takes to admit a patient from the emergency department, the communication involved with that. There are a myriad number of steps. This isn't anything about delivering care to a patient. This is just moving someone from one place to another, and all the pieces that we have to do and we have to think about to enable that to occur. So I think you can see that there are a lot of places within this for errors to occur. And again, this is a component of the delivery of healthcare, but it's really not at the sharp end. So organizationally, we searched for answers. And we looked outside of healthcare because we didn't think healthcare had the answers. And this was about 12 years ago. And where we looked was to Toyota. We looked to Lean, and that's where these sort of books all sort of talk about. And this was unique at the time in healthcare. I think in the last 12 years, Lean healthcare has really taken on, and lots of hospitals around the country are using it. I think the last survey I saw was about 60 or 70% of hospitals have employed some sort of Lean tools and techniques to improve their care, to perform quality improvement. But only about 3 or 4% have really embraced it and changed their culture utilizing these principles. So this was the journey that we started about 12 years ago to see, could we make our performance better by embracing the concepts from Toyota. So why did we study Toyota? Well, it was high quality and high reliability, the best in the industry. They had a safety record that used to say exceed, but it says exceeded because we know Toyota's had some issues over the last few years, and we can't just be blind to that. They clearly have had some safety issues, and I will talk about that in a few slides. But they are cost effective for their customers. They have a short response time. They have high levels of employee engagement and morale. And this level of employee engagement, again, is not just limited to their Japanese plants. They have the same level of employee engagement when you come into the United States and when you have their plants that they have all around the world. And the way they do this is with an organization-wide philosophy and management system. It's really their culture. And so our task was to say, can we take this culture that they have, this philosophy, and try to embrace it at the hospital? And our adaptation of that we call CPI, or continuous performance improvement. Again, it's a philosophy, it's a strategy. It has become, and it's continuing to become, the way we manage. The way we manage at a leader level, the way we are asking our line workers to manage and how they take care of patients. There are sets of tools. I'm not going to go into the Lean tool set today. And I think a lot of times when hospitals have embraced or taking on Lean projects, they're really looking at the tools. We've really tried to say, can we bring that philosophy into our organization? When we boil that philosophy down, we think about it in 3 ways. The first is focusing on the patients and the family. We need to involve patients and family in our work. We can't imagine that we know what we want. We need to listen. And this, the last bullet here, I'll talk about more at length later on, but the uniqueness of our patients should be the only variation. We shouldn't be the variable here. It really should be our patients. Again, this was hard for us to settle on, this whole point. Part of it was reluctance to ask families and their patients, how are we doing? We have events where we make improvements. We didn't want to bring them in. We were nervous about it. But the more we talked to them, the more we talked to our families, they said, well, we know all your dirty laundry. We know what you're doing wrong. You need to bring us in, and you should bring us in. And that was an important thing for us to grapple with. And I think it's helped us on our journey to make things better. We support faculty and staff in their work by giving people the opportunity to participate. Again, we don't want things done to people. We really want to utilize folks' creativity in improving. And we also have a stated point of no layoffs. Again, no layoffs. Again, if you're not performing, that's a different thing, but you don't get layoffs because you've been improved out of a job. We had some challenges with that early on where as we were making improvements to work, people in the room could see, wow, if we bring this forward, my job is gone. And that has happened, to the point that we don't need that job anymore, but we've then redeployed the person within the organization, so that was an important thing. And then we carried that forward during the recession and said we're not going to lay people off because of revenue-related challenges, and we've been able to do that by really reducing waste from our system. And we take a long-term view. We understand that this work takes a long time, and the final bullet, which I don't know if you can read back there, but it says focus, avoid the squirrel syndrome. You guys know the squirrel syndrome? The squirrel syndrome from the movie Up. The movie Up, the dogs, they have the collar, they're saying horrible things, and then a squirrel runs by and they go, squirrel. They have this ability to not focus on what's going on, but they chase after bright, shiny objects. And that's something that we want to make sure we're not doing. We want to stay focused on our mission and not let little things distract us from our vision of being the best children's hospital and our mission of providing as safe care as we can. Our approach, 3 ways really. We use leader guidance and direction. We involve staff and families. We try to understand our work, and we try to eliminate waste whenever we can. And removing waste is central to our efforts. However, waste is tricky to identify because a lot of times what we're doing really seems like it's real work, but a lot of the stuff we're doing is really wasteful. So we really try to get deep into understanding what waste is. Waste comes in many forms. There's waste of processing where we're doing things over and over again. We correct things. We have to search for things. We transport things. We underutilize our people. And we have waste of inventory. And some of that inventory is really just people. That's what a waiting room is. A waiting room is a glorified place where people wait. We built this new hospital a few years ago, and we made these beautiful waiting rooms. They had more aquariums than you could imagine. And what does that tell people? They come in, I hope you like it here because you're going to be here a long, long time, so enjoy the fish. Well, we're building a new hospital. We're building a new emergency department right next to ours, and we're not going to have a waiting room there. It is our organization's mission to not have people wait. People actually come in and see the physician, to see the nurse practitioner, to get care right when they arrive. So the opposite of waste is value added. And this is a definition that we struggled with in healthcare. Because when you really get down to it, it's an activity which changes the form or function in a way that someone would pay for it from their perspective. So we had to struggle with this about, well, do people really pay for health care? Do we want to think about things that people are paying for? But we eventually settled on it. And using this rigorous term, you really start getting at what are the things you're doing that's wasteful. Again, when we do performance improvement work, well, it's wasteful. Now, we can say it's necessary, but it's still waste. A family isn't necessarily going to pay for us to make sure that we give them the right medication and study the ways that we can do it. They expect it's going to be done the right way the first time. But we at this point feel we need to do it. So what work I'm talking about here is wasteful with this definition, and unfortunately we can't get rid of it. But there are pieces that we can get rid of. If we look at the steps within healthcare, about 90 and 95% of them are wasteful. Only 5% are really value added from a very strict definition. But we, try to understand that not everything that we do which is wasteful can we get rid of. So we then break it up a little further and we say there's necessary work, there's unnecessary work, and then there's value-added work. You know, and the necessary work that is wasteful, we want to reduce that as much as we can. We want to eliminate all the unnecessary work. And so we try to think when we're looking at a process, mapping it out and trying to understand which pieces are necessary, which pieces are unnecessary, and which pieces are value-added. And that helps give a lens for us to look through and really focus our efforts when we're evaluating our processes. One way that we like to understand things is in the CPI management system. And you know, listening to the lectures this morning, I think in some ways this is probably similar to a QMS ago. I haven't used that or heard that terminology before. That's just my ignorance. But I think maybe it's sort of similar to that in where we're really looking at having two main pillars. The one on the left is no waiting, and the one on your right is no harm. And we're really trying to keep those pillars strong. In no waiting, we are trying to do things just in time, delivering the right service, the right amount, and the right time the first time. In no harm, we want to make problems visible. We want to understand when we need to stop the line to say we have a system error here and we can't keep going because we're going to injure someone. The middle is really the tools we use about balancing standardized work and using flow, but on the top of the house is really where we focus everything. It's really on patients and families. And this for us is the house that we sort of work through and think about as we're trying to make our improvements. So over the last few years, we started again with point improvements. We were not very brave when we took on this work. We didn't say we're going to change our organizational culture overnight. We started in areas where we did not touch patients. We started in the loading dock, and we have these nice pictures. Pretty messy beforehand. We cleaned it up, and it became very, very nice. And it actually has continued that way. Our second wave, we went into clinical areas without physician leadership, so medications, laboratory, things that were very sort of process-oriented. Our third wave, we started getting into the hospital. We needed physician leaders. We standardized how we round. We standardized our research process. We standardized processes in the operating room and in clinics and in the ED and in our laboratory again. But again, these at this point really focus on operational improvements. And then we started looking at value streams where we try to understand how we're taking care of patients from the patients and families' perspective. Where historically you take a very silo-based approach. In value stream, you look at the whole patient's flow. So a patient who is there for an orthopedic procedure because they have a leg fracture, you look at their time from the ED all the way through our outpatient clinic. And so you try to improve that whole process and not just focus on one piece, but try to look at the whole piece of their care. And so we've standardized many value streams in our organization. And recently, we started on new work. The first is around this new facility. We've built a new facility using lean principles. We're standardizing our clinical work, and I'm going to talk about that at length in a minute. And then we've also standardized how our leaders work. And all this we were pretty happy with until about a year and a half ago, where it came to light, similar to Toyota, where our house collapsed. That I think we were pretty focused on this just-in-time stuff, really trying to grow our business. And I think Toyota actually did similarly. They were trying to grow their business. We were trying to grow our business. Our strategic plan of 2006 was really about growth. Safety wasn't in there. Quality wasn't in there. It was a piece of our work. It was pieces of CPI, but it was not really called out. And so we had three medication errors. And for these three medication errors, we had 3 patient deaths. And they weren't all the same week, but they were in the space of about 6 months. The last one was one of my patients, and she was very sick. She needed a heart transplant. She was on a ventricular assist device to keep her alive while she was waiting for a transplant. It was basically an artificial heart that was pumping for her. But she received a 10 times calcium overdose. There are lots of reasons. There's lots of cultural issues with it. But it was an alarm bell for our organization. We were embracing on a new strategic plan. We were just getting ready to present it to the board, and it was all about growth again. And we took a step back, And we said, should it really be about growth? Should we really be focusing on growth when we're injuring, harming, killing patients? And we have this CPI, we have this improvement work that we think is making a big improvement, but we're still not doing what we set out to do 12 years ago. And so we stepped back and we said, yeah, you know what, we need to change our strategic plan. Now we still have to focus on growth because we need to have be able to pay salaries and have people, and that's the only way we're going to be present. But we really need to focus on safety and value. And so now we came up with this strategic plan with 3 leaves. There's a leadership leaf, which is really around research to make things better for patients. There's a piece of growth, but really value has sort of really become the biggest leaf in this plan. And for us, value is really providing safe, quality care in as affordable way as possible, so as we are in a way to basically be a good steward of the resources. Again, we get lots of philanthropy from our community, so it is incumbent upon us to be good stewards of that resource. And so when we looked at value, again, this is a bit of a busy slide, but what we wanted to do is to reliably deliver safe, effective, affordable, family-centered, equitable care and provide timely access. Again, the Institute of Medicine came up with a definition of quality, has 6 domains, and these are those 6 domains. So what it means for us is we want to be a leader delivering safe patient care. We want to improve access so people can actually get our services and then be safe when they're getting the services. And then we want to limit our costs as much as we can. We looked at medication safety as really our biggest vulnerability. And so then this becomes how we're tackling it. We're developing early warning, surveillance, and response systems to be able to see when do we think we're putting people at jeopardy. What can we put in place to actually start sampling rather than waiting for something bad to occur, but actually to start understanding near misses, which is really hard for us, has been hard for us to track historically. Again, we have a focus on medication safety, and we are bringing in a new medication safety team with a physician medication safety leader and then a pharmacist and a nurse medication safety leader to really work together and sort of expand that team. We are doing clinical standard work, and I'll explain that in a sec. And then we're bringing in new EMR, electronic medical record technologies, to make things for our patients as safe as possible. So again, and this is basically just going through that at length. So I want to talk a bit about clinical standard work. So again, we have a multifaceted approach to make patients safer. But our first area that we started working and we have started working on is in clinical standard work. So this is a graph which shows the improvement or the survival of patients with leukemia over the last 50 years. And you see that in 1950, it was generally fatal for a child to be diagnosed with leukemia. And over this 50 years, we now have a 90% survival rate in the last decade. And this didn't happen by chance. This happened through rigorous study. Every patient with leukemia, for the most part, is on a research protocol. We learn from these patients. But the way we learn is that we've standardized their care, and we make small changes, and we learn from these small changes. So this became sort of our vision for clinical standard work. How could we standardize care in a way that we make things similar, but that we start actually to learn and to make things safer and better? So our vision for this work is to improve the quality, safety, and timeliness of care by applying the principle of standard work. And standard work is really standardized protocols, standardized checklists, a standardized approach to clinical practice. We have a 5-year goal of putting 50% of our patients on clinical standard work pathways. When we started this work, we had about 8 or 9%. So now we are in our first year. We started last year, but really started this new strategic plan in October. We're now up to 18% as of last week. Our goal for this year is 20%, so I'm optimistic that we will make it. Again, this is really a process metric that we're putting patients on the goal. Our real goal is to do what's on the bottom right, which is to improve the harm index, which is an index we're developing to see actually what percentage of patients are being harmed in our organization. Our goal is to drive that down, this being one of the ways that we are hoping to accomplish that. So clinical standard work has 3 components. It is a documented approach to management and treatment. Again, we base it in evidence when available, and when not, we use consensus. Again, in pediatrics, the evidence base is not nearly as great as adult medicine. So we have a much smaller evidence base that we can work from. And so we have to rely on consensus. But that becomes why we're doing this. Again, by standardizing care, we hope to actually learn, so we can actually develop evidence as we go forward. We hardwire the care with order sets, which is part of our electronic medical system, with standardized case carts in the operating room, with checklists, with other tools to try to make things similar. And then we actually make sure that someone is actually owning the process and that we're following metrics. So our conceptual model for this is really going from our current state where we really have provider-generated variability in healthcare, where the care you receive is really dictated by who you see. But we want our future state to be where the care that's received is dictated by the patient's variability. And not by what the provider sort of comes into the room with. And we're clearly not there, but that's our goal. Go through that. So we've established process flows and how we do. We have a sort of a rigid preparation phase, development of the pathway phase, implementation phase, and then an improvement phase. And this is an example. So this is acute gastroenteritis, AGE. And this is a rigid approach on how we're managing patients with gastroenteritis. Now, patients can fall off of the pathway. So when I say rigid, I don't mean everybody has to be going down a certain pathway. But this is our standard approach. So when a patient deviates, we now can understand it. We now can see that they're deviating. Where if you don't have a standard approach, you have no idea. We standardized how we took care of asthma 10 years ago. We had a length of stay of asthma 5-6 days. Now it's down to 1.5 days. Patients aren't bouncing back. They're getting better quicker because we have a standard approach. So we've taken those concepts and trying to spread them throughout the organization. This is how we train patients, how we train our providers. This is just how we, for urinary tract infection. And so over this starting last year up through this year, we have developed 19 different pathways based on diagnoses, and we have another 21 that are in queue. We intend to have between 40 and 50 of our pathways standardized. Again, I think in adult practice, you see some of this a lot more than in pediatric practice. But for us, this is a major change, a major organizational change for us to try to make care standard and safe. So this is just an example of, these are the projects that we currently have for this fiscal year, which ends in October, ends in the end of September, and then the ones that we're sort of getting ready to kick off for 13. And this is just showing where we were. About 17.4% of patients were standardized. As part of this, we really need to make sure we're tracking patients. We need to make sure we're tracking things for a variety of reasons. We track our length of stay, we track our charges, we track readmissions, and then we track our compliance that patients are actually on the order sets. Our eventual goal is to move the harm index lower. And within each specific pathway, we have very specific outcome metrics that we've asked the clinical content owners to give us, to generate, and then we're helping them follow. So in summary, this work that we're on, this path that we're on for continuous performance improvement and now clinical standard work, it's hard work. It's taken us a long time. It's taken us a long time to see results. Again, we think we're seeing the process metrics go in the right way, but the outcome metrics will take a while. But we found that it is engaging for our staff, faculty, and families. But we have had a lot of investment of people's time, financial, and of leadership's time and focus. And with that, I'll stop, and thank you for your attention.